dynamic stabilization of the spine. And I have a conflict of interest with Cousin Biotech, who is doing this device. So what is the motivation of the surgeon? We talked about that point this morning. Of course, the motivation is to try to reduce the rate of revision surgery, because the rate of revision surgery in fusion, in all series of fusion, is nearly 20% at 7 or 8 years follow-up. So it is important. And as you know, the results of our patients with fusion is not always so good. And in this paper done by Park, the incidence of revision surgery is from 2 to 3% per year. So the result of fusion with quality of life is not so good. And as you can see, 15% of patients reported being somewhat worse or much worse at 1 year follow-up following a fusion. So this is not really good, and we want to try to improve these poor results. So in Bordeaux, we tried we work since more than 30 years ago with Professor Senegas. He developed the interspinous devices. First one was in titanium, and then it was with a PIC, it was the Wallis system. So we use a lot of Wallis system in Bordeaux by the pass. And we review a series of patients operated the Wallis system, more than 100 patients. And as you can see, the follow-up of this patient is quite good, with decreasing of the lumbar pain, decreasing of the radicular pain, and with improvement of ODI score also. And but we have 14% of recurrence of herniation in our series, and we can say that the device, the interspinous device in our study, was not able to reduce the herniation recurrent rates. We had also one spondylolisthesis after implantation of this device, and in 14% of patients, we need to remove the implant. So Virginie Lafage has shown that interspinous device is able to reduce range of motion in flexion extension, but in fact, interspinous device has no effect in lateral bending or rotation. And this is not surprising, because interspinous device is implanted on the medial line, so it is impossible to reduce forces in lateral bending or rotation. And Floman showed that, Kim compared 62 patients operated of lumbar surgery with and without DIAM. DIAM is similar to Wallis, and he has shown there was no difference in terms of pain score and McNabb outcome scores. So this is the so that's why we proposed the new system with the pedicular screws, and there is in the BDyn system a viscoelastic ring, a viscoelastic spring also. There is a shape in 10 degrees of lordosis with the polyaxiality of the upper rod, and so this dispositive and limit distraction compression, limit lateral bending, and limit also flexion extension. So there is a security stop of 2 millimeters, so compression is limited at this length. So we made, of course, in vitro biomechanics evaluation to study the influence of the BDyn on the functional spinal unit mobility, the intradiscal pressure, the articular facet loads. And so we have shown that BDyn decreases range of motion, decreasing facet loads in axial, mostly in axial rotation, and decreases disc pressure in anterior part of the annulus, in the nucleus, and also in posterior part of the annulus, mostly in extension. So the key point, in fact, in dynamic stabilization in the indication, and we can discuss long time about indication, and I will show you some example. This is a male, 56-year-old, suffering from left cruralgia without motor deficit, and he has, as you can see, a foraminal stenosis. So, of course, it is possible to do a mini-invasive decompression of this stenosis, but in my hands, you know, there is a high risk of postoperative instability, of iatrogenic instability, and it is a good option for me to do a dynamic stabilization of this level. If you want to do a fusion, which level will you take in your construct? There is, it is starting a spondylolisthesis at this level. The disc above is not so good, so dynamic stabilization probably for me is the best option, and we can do a unilateral construct and opening of the foramen. Another example, thoracolumbar scoliosis. Look, this patient, she's 74-year-old with neurogenic claudication. Here she has spinal canal stenosis at both levels, L2, L3, L3, L4. With a dislocation, we can see this dislocation on L3, L4 level. So it is really common, this type of patients. So what kind of surgery do you propose? Decompression alone or fusion? But if you do a fusion, you will stop the fusion at the top of the deformity, and as you know, it is not recommended. So probably you could also propose a long fusion from T12 to the pelvic, but it is really aggressive for this patient. And for us, also, it is a good option to do a dynamic decompression, of course, and dynamic stabilization, short dynamic stabilization at 2 levels. So we propose in scoliosis, in deformity, dynamic stabilization only if there is no dislocation on AP view above the construct, no spine imbalance, and no compensatory mechanism, because in that cases, we prefer to do a fusion and correction of the deformity. Another example, a degenerative spondylolisthesis with a articular cyst, and the previous talk have shown this kind of indication, and for me too, it's a really good indication to do for that pathology a dynamic stabilization. And we started a multicentric study comparing dynamic stabilization in L4, L5 degenerative spondylo with fusion. Only we published this classification on degenerative spondylo in European Spine Journal only in type 1, because if you want to do dynamic stabilization when there is imbalance, you will have a failure. If you want to do dynamic stabilization when you have pelvic compensation, you will have also a failure. You need absolutely in tape 2 to restore lumbar lordosis. So this is a prospective randomized study only in type 1 degenerative spondylolisthesis. So another example, perhaps dynamic stabilization will be able to reduce the rate of PGK, and we do some cases using dynamic stabilization on topping off of long construct. And also adjacent syndrome. This patient is 51-year-old. He had the prior fusion at L4, L5 level 3 years before. He has neurogenic claudication with a walking distance, with a short walking distance. So this is the MRI, so prior fusion at L4, L5. So what did you propose? Perhaps to extend the fusion, of course, it is an option, but for us to avoid further adjacent segment degeneration, we proposed just a topping off at L3, L4, and of course also associated with the decompression of this level. Another example, a hypermobility at L4, L5 level. This is really interesting because I made a dynamic stabilization. You see, dynamic stabilization decreased the mobility at the operated level, but I do no more this type of dynamic stabilization for this indication. Why? Because I had in several cases screw breakage. Because if you have a preoperative hypermobility, I think it's not a good indication for dynamic stabilization. Your material and the screw will be too much solicited. There were too much stress on the screws in this indication. So in hypermobility of Kirkcaldy-Willis instability, I prefer to do to avoid dynamic stabilization. So this is our series of 76 patients. 2 patients were died, 2 patients lost of view, and 2 patients were not reviewed. So as you can see, in all of our patients, we do neurogenic decompression. So fenestration or herniation, and of course, this could also influence our results. We don't know if the patient is improved by the dynamic stabilization system or by the neurogenic decompression, of course. And a lot of our patients had a preoperative stenosis or 18 degenerative spondylo, and in this series, 4 patients with the scoliosis. So surgery, most of the instrumented level were at L4, L5 level or L3, L4 level. And as you can see, we do fenestration in 70% of cases, herniectomy and laminectomy. And in most of the cases, we do one level dynamic stabilization in 50% of cases. So we had adverse events, of course, with 3 revision surgery for 1 infection and 1 discal herniation above the operated level and 1 adjacent segment disease at 4-year follow-up. So this is our clinical results about pain, lumbar pain and radicular pain. And you see that usual functional scores are improved after the surgery. But again, the question is it due to the dynamic stabilization or due to the neurogenic claudication? It is impossible to know. So there is some point to be more clear in the... So we had also 4 screw breakage before 2014, because at that date, the shape of the screw was changed, and now we don't have anymore. And 2 screw loosening in our series. So this is, of course, the big problem. We talked about that before with the dynamic stabilization system. So there are no changes in pelvic parameters after dynamic stabilization. This is normal because a dynamic stabilization system is unable to do some reduction maneuvers. It's not the goal. And the mobility, you can see that at the index level, dynamic stabilization reduce the mobility of 50% without changes, statistic changes at the level above and the level below the index level. So in conclusion, for me, this is promising results, and this is really useful in some cases, as I shown. Results, we can't say that it is better than fusion, but of course, again and again, we need more data, and so that's why we started a multi-center randomized control study for this BDyn system. Thank you.
Thank you very much for the nice lecture. Any questions or comments from the floor? Dr. Gille.
Thank you very much. Very good series. I would like to know the cases with stenosis. You operate a lot of stenosis cases with dynamic stabilization. Why didn't you perform just decompression.
Mhm.
If there is there any instability findings, or just this was a preventive
Yes.
surgery?